This phenotype, ceftazidime avibactam equals MIC16R, ceftolozane tazobactam equals MIC8I, cefiderocol MIC0.12S, imipenem/relebactam MIC2/4S, despite imipenem 8R, is internally consistent with a Pseudomonas aeruginosa strain in which classic chromosomal mechanisms, AMP-C pathway plus or minus efflux, plus or minus partial permeability changes dominate. In contrast, the specific determinants that typically erode cefiderocol activity, iron uptake defects, and certain acquired beta-lactamases are absent. The key microbiology question is which combination of AMP-C structural/expressional changes, efflux, and porin/permeability alterations can explain the differential behavior of the newer agents. What it immediately suggests, you have pan-anti-pseudomonal beta-lactam non-susceptibility for the legacy agents, piperacillin tazobactam, ceftazidime, cefepime, aztreonam, and carbapenems, imipenem/meropenem, both 8R. Fluoroquinolone resistance and polymyxin B intermediate add to the DTR-ish picture, but two escape hatches remain: cefiderocol, very low MIC, and imipenem/relebactam, right around the susceptible cutoff. That combination strongly points away from a metallo-beta-lactamase, MBL, producer, VIM/IMP/NDM, as the primary driver, because MBLs usually wipe out imipenem/relebactam and frequently raise cefiderocol MICs, depending on the enzyme/background. It also argues against the specific cefiderocol resistance axis, PIU/PIR, iron transport disruption, and / acquired beta-lactamases like VEB/NDM in particular, that tends to increase cefiderocol MICs. Mechanistic triad in Pseudomonas: AMP-C, efflux, permeability. Most real-world Pseudomonas beta-lactam phenotypes are composites of 1. AMP-C, Pseudomonas-derived cephalosporinase, PDC, derepression/hyperproduction, and/or structural PDC mutations. 2. Multidrug efflux upregulation, MEX-AB-OPRM, MEX-XY, etc., and sometimes structural pump mutations that broaden substrate profiles. 3. Reduced permeability, classically OPRD loss for imipenem. Other OM changes can contribute more broadly. The newer beta-lactam/beta-lactamase inhibitor combinations, BLICs, differ mainly in how well the inhibitor handles PDCs and how vulnerable the partner beta-lactam is to the specific AMP-C variant plus efflux plus permeability state. Reviews and in vivo evolution studies repeatedly show AMP-C omega loop and other active site adjacent substitutions and regulator mutations as central to CAZ-AVI resistance and to cross-resistance patterns across newer beta-lactams. Why ceftazidime/avibactam is resistant, MIC16, while ceftolozane/tazobactam is only intermediate, MIC8. For Pseudomonas, ceftazidime avibactam failure most often maps to one or more of the following, frequently in combination. 1. Structural PDC, AMP-C mutations that favor ceftazidime and/or reduce avibactam's protective effect. A classic concept is that mutations in/near the omega loop can widen or reshape the active site such that ceftazidime is hydrolyzed more efficiently and/or avibactam inhibition is less effective in the overall cellular context. In treatment-emergent CAZ-AVI resistance, AMP-C substitutions and/or regulatory mutations causing AMP-C hyperproduction are repeatedly observed, and cross-resistance to ceftolozane tazobactam is common. 2. Marked AMP-C hyperproduction, regulator hits, plus or minus efflux upregulation. Even if avibactam inhibits PDC reasonably well in vitro, mass action at very high AMP-C expression plus simultaneous efflux/permeability changes can produce clinical ceftazidime avibactam resistance. Importantly, efflux is relevant not only for the beta-lactam, but can also reduce intracellular inhibitor exposure. Newer reviews emphasize efflux as a contributor to resistance for BLICs. 3. Acquired class D beta-lactamases, OXA2/OXA10 family, and or other acquired enzymes, for example, some GES/KPC variants, in the right background. Acquired enzymes can push ceftazidime avibactam over the edge, particularly when layered on AMP-C/efflux. This is a check for it item, not something you can prove from MICs alone. Why then is ceftolozane tazobactam not fully resistant? Ceftolozane is intrinsically more stable than ceftazidime against wild-type PDC and was designed to better withstand the intrinsic Pseudomonas resistome. But it still loses potency with certain PDC variants/hyperproduction and with efflux/permeability layering, so it often falls later than ceftazidime, hence intermediate here. The fact that ceftazidime avibactam is outright resistant while ceftolozane tazobactam is intermediate is a very common clinical ordering when the dominant mechanism is AMP-C pathway evolution plus efflux. The most informative contrast, imipenem resistant, 8, but imipenem/relebactam susceptible, 2/4. This specific reversal is the signature clue. If carbapenem resistance were driven primarily by OPRD loss, a permeability mechanism that especially impacts imipenem, adding a beta-lactamase inhibitor would not reliably rescue imipenem because the drug cannot reach PBP targets. When imipenem is R, but imipenem/relebactam becomes S, it strongly suggests that a major component of the imipenem resistance is beta-lactamase mediated, that is, AMP-C-driven hydrolysis, often de-repressed AMP-C, possibly with contributing mechanisms, rather than complete OPRD abolition as the dominant driver. Relebactam is a potent inhibitor of class A and class C beta-lactamases, including AMP-C, so it can restore imipenem activity in strains where AMP-C is a key contributor and permeability is not the sole/absolute limiting step. Put differently, your isolate looks like AMP-C heavy carbapenem resistance more than pure OPRD null carbapenem resistance. Two additional subtleties that often matter in Pseudomonas. MEX-ABO-PRM classically exports many beta-lactams but has limited effect on imipenem relative to other agents. Thus, even if efflux is up, imipenem can sometimes be rescued once AMP-C is inhibited, whereas ceftazidime remains much more vulnerable to the combined AMP-C plus efflux milieu. This imipenem/relebactam MIC 2/4 sits close to common breakpoints, and real-world test performance for imipenem/relebactam can be method-dependent. Confirmation by a reference method, broth microdilution, is often prudent when results are borderline or discordant with expectations. Why does cefiderocol stay very susceptible, MIC 0.12, despite broad beta-lactam resistance? Cefiderocol's Trojan horse entry via iron transport, siderophore-mediated uptake, plus its stability against many beta-lactamases gives it two big advantages in exactly this kind of isolate. 1. It partially bypasses the permeability bottlenecks that hurt many beta-lactams. It uses active uptake pathways rather than relying only on porin diffusion. The major cefiderocol resistance routes in Pseudomonas often involve iron uptake pathway alterations, for example, PIU/PIR systems/regulators, and/or certain acquired beta-lactamases, notably some ESBLs/carbapenemases, in the right background. Studies of cefiderocol resistance emphasize multifactorial mechanisms, especially acquired beta-lactamases, for example NDM, VEB, and impaired siderophore uptake, which can drive cefiderocol MICs markedly upward. The MIC of 0.12 argues that those mechanisms are not present or not expressed in a way that matters phenotypically. There's also an epidemiologic point embedded in global datasets. Even among carbapenem-resistant Pseudomonas, cefiderocol often retains high in vitro activity, but when cefiderocol MICs rise, they tend to correlate with resistance to ceftazidime avibactam and ceftolozane tazobactam, and with the siderophore/beta-lactamase mechanism set described above. Your isolate shows CAZ-AVI resistance and C/T compromise, but still has a very low cephadurocol MIC, consistent with AMP-C/efflux-driven BLIC resistance without the additional cephadurocol-specific hits. A plausible, best-fit mechanistic model for this isolate, phenotype level. One coherent composite explanation that matches all four drugs. Baseline background: quinolone resistance, likely QRDR mutations, and polymyxin intermediate, adaptive LPS regulatory changes possible, plus a multi-drug resistant membrane/efflux baseline. Beta-lactams: derepressed/hyperproduced AMP-C, PDC, plus efflux upregulation leads to resistance to ceftazidime/cefepime/piptazo/aztreonam. Newer agents. CAZ-AVI, defeated by AMP-C pathway evolution, hyperproduction and/or PDC structural mutation, plus or minus efflux leads to MIC16R. C/T, more robust than ceftazidime, but still impacted by high AMP-C/variant PDC, plus efflux leads to MIC8I rather than fully S. Imipenem, pushed to R by AMP-C, and possibly partial permeability/other factors, but relebactam blocks the AMP-C contribution sufficiently, leads to imipenem/relebactam MIC returns to S. Cephadurocol, iron uptake pathways intact, no major cephadurocol compromising beta-lactamase constellation expressed, leads to very low MIC, 0.12 S. This is also aligned with observed cross-resistance tendencies. Ceftazidime-avibactam resistance frequently travels with ceftolozane-tazobactam non-susceptibility, whereas cefiderocol is often least affected among the newer agents unless iron transport or specific acquired enzymes are involved. Be careful with isolates like this one, and remember, call the ID specialists.